Ladies and gentlemen, good morning. I've been asked to give a talk on Priapism and whether the UK centres have led the way, and this is not actually a straightforward talk as I thought it would be. My interest in Priapism started in 2001 when Asif Munir and I started smooth muscle dysfunction research at UCH. And I was asked to write a review back in 2002 with Sux and David. And I think quite a lot has changed since then. And I'll try and tell you why. So I started off by doing a Medline search of Priapism. And there's 2,600 papers out there. What's striking straight away is the lack of randomized controlled trials and multi-center trials. And most of the evidence comes from case reports from specialist centers. If you look at the lowest slide, there's 88 references from the UK, out of 2,600. So on first analysis, you would think the UK hasn't had a big impact in Priapism, but I think it probably has. I just want to mention Gareth Brown's recent survey of UK Priapism practice at this point, which showed that 97% of us in the UK were required to look after Priapism patients regularly, but the majority of us only saw one case annually, with only 7% referring cases, but the majority felt that they could get advice from an appropriate centre if required. We as a nation seem to be more confident in aspiration rather than installation of vasoactive agents. And about 70% of us had performed a distal shunt procedure at some point. The vast majority, 7 out of 10 of us, were aware of the existence of guidelines, with the EUA guidelines not surprisingly the commonest known. And most of us expressed interest in UK-specific guidance, just as Asif Munir discussed earlier. We all know what Priapism is. It's a pathological condition with a prolonged erection for over 4 hours. And it can occur at any age. But it's certainly more prevalent in sickle cell patients than any other group. And this is an early study from 2002, I think it was, from the northwest of London and of Nigeria, which showed up to 35% of all sickle cell patients would have a Priapism episode at some point in their life. And this got more prevalent as they got older. Referring back to Asif Munir again, his work looked at a number of factors in vitro. Well, one of the things it looked at straight away was time-dependent changes. And as you can see in the left-hand side graph, there's a sudden reduction in restoration of smooth muscle relaxation between 1 to 2 hours and irreversibly at 4 hours. So I think that 4-hour definition probably is correct. There are 3 types of Priapism, and I'm sure we're all aware of that, but there's a number of different terminologies used. Ischemic, low flow, arterial, high flow, or stuttering recurrent episodes. Starting with ischemic low flow Priapism, this is by far the most common, and the majority of us will see this perhaps once a year. Typically presents with a painful erection with absent or very low arterial inflow. And as I mentioned, there are time-dependent changes resulting in hypoxia, hypercapnia, and acidosis. And again, looking back at the same group's work, as if I'll put your picture up there, just in case no one knows what you look like. But if you look at the graphs below, you'll see these are, as time progresses, there is less and less reversibility of the smooth muscle changes in vitro. And before 4 hours, you get compartment syndrome with supraphysiological pressures, resulting in compromise of the cavernous circulation. And we all know that emergency medical intervention is required to minimize the consequences, such as fibrosis and ED. But where's the evidence? So there is good evidence that as time goes on, histologically, you get replacement with edema, destruction of the endothelium, exposure of basement membrane, and formation of fibroblast-like cells in up to 48 hours. So there is a window of opportunity there. I think what's become very well established in the last 16 years is a diagnostic pathway in distinguishing ischemic and non-ischemic Priapism. A combination of history, clinical examination, and specialist investigations, such as aspiration, which can tell us, when the PO2 is less than 40, it's very likely to be low-flow priapism. However, what's the role of Doppler ultrasound in the evaluation of these patients? And I think this paper recently published from the UCLH group helps define that role even better. What they found is in 50 patients, they divided them into ischemic and non-ischemic on sound wave, and the top trace shows a typical pattern of low mean pressures. The second slide shows a second subgroup where patients had had some kind of intervention before the Doppler, and you can see it's a mixed pattern. The third is high flow. I think the importance here is to establish that you can diagnose or help to diagnose ischemic high flow on Doppler ultrasound, but really Doppler ultrasound should be done before any aspiration. What's the role of MRI? Again, the UCLH group looked at viability on MRI and correlated it with corpus cavernosum biopsies in 22 patients. And in those patients, they found 100% correlation. The MRI was looked at by 2 independent radiologists and 1 pathologist. So I think in specialist centers, certainly MRI is a very good tool. The question is availability in non-specialist centers. Again, what's well established, I think, is the algorithm of how we initially treat priapism, moving from initial conservative measures to irrigation and then to vasoactive agents. But shunts should really be used as second-line option when at least 1 hour of conservative therapy has not worked. A number of shunts have been described over the years, and the picture shown on the right there demonstrates a more and more invasive approach to shunting, from a Winter shunt where you use a true cut biopsy, to Eberhard shunt where you use 11 blade, to a T-shunt. But is there any evidence that this works? And I think the best evidence is for the T-shunt, which is where you use this variation of the T-shunt with the snake maneuver using tunneling. And again, the UCH group and Evangelos Sakarakis presented this very good paper, I think, which shows that I think certainly within the first 24 hours, this is the best way to shunt. And there's 100% reversibility in the first 24 hours, resulting to over 30% at 48 hours. Interestingly, if you look at the slide on the right-hand side, looking at the Ieft, all patients who presented over 48 hours had severe ED, and most of them required a penile prosthesis. Proximal shunting seems to be reserved for centers where maybe distal shunting hasn't worked. What is the evidence? I couldn't find any UK experience or long-term studies looking at this at all. And I think this probably has now been superseded, I think, by the management of low-flow priapism with the immediate insertion of a penile implant. This was the first paper that in the UK that Roland presented. Only 8 patients to start off with. But even then, in 2002, showed that 7 out of 8 patients had no problem at all. It restored their length and minimized fibrosis. This has now been superseded by a more recent paper with 50+ patients. And again, it shows very, very good long-term outcomes. These malleable implants can be upsized if needed. And a number of patients, up to 92% of patients were completely satisfied. So I think there is good evidence for now the insertion of an early implant. The question is timing. So it does prevent fibrosis, it maintains penile size. I think there are no clear indications for timing, but I certainly think any ischemia greater than 36 hours, where primary agents have clearly failed, where there's been a failure of shunting, and where there's MRI or histological biopsy evidence of fibrosis. These are very good options for implant, and I think the UK has led the way here. Moving on to arterial or high-flow priapism. This is rare, and the evidence really comes from very small case series indeed. As we're all aware, this is usually associated with some kind of perineal or penile trauma, but very occasionally it does occur secondary to some kind of surgery, like even optical osteotomy and Nesbit's in case series. And this results in unregulated flow, persistent ejaculation, and turbulent flow. There is often a delay between the injury and the onset of ischemia. And generally, we've thought that this is not an emergency. But again, this paper from the UCLH group, I apologize for mentioning UCLH again and again, but they seem to be the center with the most experience, shows there's 6 patients over a 5-year period that had high-flow priapism. And they were evaluated serially. And all of the patients did, in time, develop either distal flaccidity or reduction in their erections. And I think what this paper evaluates and tells us is that we probably should be doing embolization earlier than we anticipate, and certainly need a close follow-up for these patients. Certainly saying to these patients, we'll keep an eye on you remotely probably isn't appropriate. There are other ways to treat high-flow priapism apart from embolization. Conservative measures such as ice, anti-androgens, but I think embolization has the highest success rate, up to 90%. There is controversy as to what you should use. Going back to 2001, I found a paper from Sandy Gridgerol from the Bristol group, which showed one of the early evidence using microcoils. So I think it really depends on radiology choice, and probably autologous materials probably are better than coils. Moving finally on to stuttering priapism. Again, epidemiological data is lacking, but it's certainly much, much more common in sickle cell patients, between 42 and 64%. The etiology is very similar to ischemic priapism, and lots of work have been done in the US regarding this. But these patients are at increased risk of an acute priapic event. These erections usually are self-limiting, but the key is to try and prevent the ischemic event. Another paper looking at the review of this from UCLH over a 25-year period, looked at 60 patients. Historically, we've used anti-androgens and cyproterone, which seems to work quite well, but there is more and more evidence that using PDE5 inhibitors in this group certainly is helpful. There seems to be a dysregulation in the cyclic GMP PD5 axis. A very early paper from the St. Thomas's group shows the use of etilephrine, which is a long-acting alpha agonist for these patients, and this works well in up to 70% of cases. So in terms of stuttering priapism, these are the EUA guidelines based on small case series. And I think the key with this is you've got a number of options now to treat these patients, including anti-androgens, PDE5 inhibitors, and other systemic drugs. And some patients are given intracavernosus self-injections to take home, such as phenylephrine. In summary, there have been many papers, but most of them from the UK have been review articles from the Northampton group, from Southampton, and more recently from Guy's. And Asif Munir and David Raff have done a recent review article looking at the EAU guidance versus the AUA guidance, but there are no BAUS guidance currently, okay? But I think the key with this is that all of us now recognize that there are 3 different types of priapism. It's to differentiate between the two, there's a now standard algorithm between the 3, sorry. Refractory cases of ischemic priapism should have shunt surgery early, which have a low threshold in referring to tertiary centers for a penile prosthesis insertion. And failure of treatment signifies smooth muscle necrosis. So in conclusion, Mr. Chairman, ladies and gentlemen, I think the UK has made a significant contribution to both the epidemiology, the preclinical and the clinical studies, and treatment of priapism. It's difficult to say whether we've led the way or not, but there are some unanswered questions. such as the use of MRI in non-specialist centres, the use of Doppler ultrasound out of hours, who should perform the shunt surgery, where and when should the patient be transferred. And I think, as Asif mentioned at the beginning, I think the establishment of UK-specific guidelines would further help patient management. Thank you.
Thank you very much, Giles. An excellent summary of UK practice and current guidance. Just an observation, I'm surprised there's as few as just one case a year in most UK centres, certainly in the southwest, where we have a very low sickle cell population. I would say we get more, the centres around the southwest get more than one case a year, so it's just an observation.
Richard, if I could answer that. I mean, I think a lot of the epidemiological studies, if you look from the US, it's variable. It's completely variable. And I think this was just a snapshot of UK practice. Probably you're right. Probably this is underreported, and I think actually the establishment of guidelines would probably mean that people such as yourself, especially centres, would see more.
Yeah, thank you very much. Questions from the audience, please. Nobody got any questions on priapism? Gentleman over there in the corner, I can't quite see. There's the light.
Hi, I'm Srijit Banerjee, one of the trainees. Is there a role for phenylephrine in treating priapism?
Yes, yes. I mean, so it's one of the it's in the algorithm. I think certainly if you look at the literature, phenylephrine has got the most experience and is probably the most effective with the least side effects in the cardiovascular. There is sometimes a shortage in getting phenylephrine, I know from personal experience, but I think probably is the best option in after you've done aspiration, washout, and then the use of vasoactivation agents. But as I mentioned, the UK survey suggested that certainly we are all more familiar and confident using aspiration and irrigation rather than vasoactive agents.
Regarding getting the phenylephrine, from conversation with our anaesthetists, all cardiac units have it, but of course not all hospitals have a cardiac unit, but all maternity units usually keep it there.
Yes.
There's a maternity indication
yes.
for it, so there's usually an ampule of it or two in the maternity unit.
Very true.
Raj.
Just a quick comment about what's coming up later on the NHS England commissioning of prostheses. I know it's a little backdoor route, but major provincial centres who are currently not able to put in prostheses, we need to actually say we should keep some in stock of the semi-rigids for placement in cases of priapism. I know we'll be tackling the issue head on, and we will be, but I think this is another reason why we need to have prostheses in those centres with experience in treating priapism. There's no point referring to a tertiary centre if we aren't funded to do the thing.
No,
so that's one of those mandatory funding things, I think.
I completely agree with you, Raj. I don't know what it's like in Bristol, but certainly down in the far southwest, we've been funded for some years, and we always keep one of each of the malleable prostheses for that, and it's always been funded if I put them in an emergency with priapism. The argument always being is I didn't have time to fill in the exceptional funding forms, so therefore it would be pointless.
I think that's a good point. There are also units, for instance, in the Northwest, we struggle with funding. And the problem is, because the malleables are penile prostheses, that's not taken into account in the emergency setting. So in theory, the hospital is covering the cost of the malleables, which is a bit difficult. So hopefully that will be cleared up in the commissioning guidelines.
Any more questions? Gentleman in the corner.
Yeah. Jim Voss, one of the registrars down in Wessex. So I was stuck with one of these fairly recently, and I'd want to know at what point you refer. If phenylephrine and aspiration fails, would you like to see us, not in the tertiary centres, trying to perform a shunt under general anaesthetic? And at what point exactly do you want them referred to places like UCH for a prosthesis?
I think that's a really, really good point, and that's where the controversy still hasn't been answered. Certainly, I think shunt surgery works within 24 hours. In many cases, and certainly if you use the T-shunt with tunnelling, and if you've got the experience to do that, I think within 24 hours, it seems very reasonable to do that. But certainly failure within the first 24 hours, I think, looking at the literature, not just UK, but worldwide, I think we probably need to put these implants in earlier.
Thank you.
I'll draw that Is there another question?
Yeah.
Another question. Last question then.
Nigel Borley. How do you feel about giving PDE5 inhibitors to sickle cell patients? And do you think there's any potential there to prevent the first episode?
Nigel, a really good question as always. I think that's the one group where these PDE5 inhibitors have been used. There was a recent randomized trial looking at this in sickle cell patients, and certainly there was only a marginal benefit with PDE5 inhibitors, but certainly it doesn't seem dangerous. It's paradoxical, and the preclinical studies show that there's a dysregulation in the cyclic GMP and PDE5 pathway in those patients. So I personally would I would give it after full counselling. The benefit seems marginal, but it certainly doesn't seem dangerous.
Thank you very much. Thank you, Jazz.